Good afternoon, or good morning, depending on your time zone. My name is Michael Blau. I'm a partner and chair of the Industry Teams Department here at Foley and Lardner, and I have the honor of welcoming you to today's webinar, CMMI's New Oncology Care Model. Is it right for your organization? I'm very pleased to be joined today by a panel of terrific guest speakers. Their names are up on the slide. You can see Dr. Kavita Patel. Dr. Patel is the Managing Director of the Engelberg Center for Health Reform at the Brookings Institute, and she has served as a technical advisor to CMMI on the design of this, what we affectionately call OCM, the Oncology Care Model, and has worked on its development with CMMI. We're also joined by Ronald Barkley. Ron is the president of the Cancer Center Business Development Group, and I'm also proud to say that he is a co-founder with me, believe it or not, of the Cancer Center Business Summit, and the Summit is a forum for advancement of best business models in community oncology. As you can see from the speaker slide, the agenda today is I will start with a bit of an introduction and overview of the OCM, and then Dr. Patel will talk about the OCM practice requirements and certain of the unanswered evolving issues, some of the technical issues that are being worked on within CMI currently. And Ron will then wrap up the program with a discussion. He'll take a bit of a deep dive into the OCM economics and talk about the application and selection process. Before we get to that, though, I've been asked to read you a little bit of some housekeeping matters here, so bear with me for a moment here. Today's program will run for 1 hour, and we will apply for one general CLE, continuing legal education credit. Anyone wishing to receive credit for today's program must enter the code when it's announced during the polling question. You'll see a slide come up with a polling question, and you'll need to put the code in it. All New York, New Jersey, and Kansas attendees that are applying for CLE credit must also fill out an attorney affirmation form and write down the code that you'll see. The attorney affirmation form and today's slides can both be obtained at the resource list that you'll see at the bottom of your screen. New York attorneys who have less than 2 years of experience will not be able to be eligible for CLE credit today. When you complete your attorney affirmation forms, please mail them to Christina Wade, and I'll give you her email address. It is cwade@foley.com. That's CWADE @Foley, FOLEY.com. If you have questions during today's program, they can be submitted by the web conference by entering whatever your question may be in the Q&A box. You'll see the Q&A box is open on the left-hand side of your screen, and we'll try to answer your questions at the end of the program to the extent that time permits. So with that, let's launch into a little bit of an overview. If I get, there we go. A little bit of an overview of the OCM program. So OCM, the Oncology Care Model, is one of a series of tests, of experiments, of alternative payment arrangements that CMMI and CMS have been piloting to try to move the Medicare fee-for-service program from a program that currently pays for quantity to one that pays for value and quality, and that improves quality, reduces costs, and provides for a better patient-centered patient experience. In other words, that advances the so-called triple aim of healthcare. And I've listed for you on this slide most of the more recent programs that have been instituted by either CMMI or CMS toward that end. And one of the takeaways is that these programs need to be coordinated with one another from a sort of technical perspective. So for instance, if you want to participate in the new oncology care model, you cannot participate in the the Transforming Clinical Practices Initiative, the TPCI. And if you're already going to participate in the chronic care management program, you're not going to be able to be double paid, that is, get paid for the same patient, the same beneficiary, as you're being paid under the OCM program. You also need to coordinate with the Medicare Shared Savings Program. If you're going to get shared savings under that program, you can't double dip and get shared savings under the OCM program as well, and there are technical ways to assure that that will not occur. So what is this program all about? The program is an episode of care program for chemotherapy. That is, chemotherapy episodes of care of the 6-month duration. And it is intended to be a 5-year program. That is, you can participate for 5 years. And for those that participate, if they are oncologists that provide chemotherapy for treatment of any of a number of high-volume cancers, and it's intended to cover about 90% of all cancers that Medicare beneficiaries may experience, particularly the larger cancers that you can imagine, from lung and breast and colorectal to ovarian, leukemia, lymphoma, and the like. All of these will have episodes of care that are associated with them. If you participate in the program, you will be able to be eligible, in addition to your Medicare fee-for-service payment, you'll be eligible for 2 different additional levels of payment. The first is for intensive care management of these patients, for patient navigation, for trying to avoid avoidable hospitalizations and readmissions and emergency department care. And for that, you'll get paid a fixed fee, a per member, per beneficiary per month fee, and I'll show you that in a moment. Then in addition, you can also qualify for a performance bonus based on meeting specific quality and cost reduction standards, and I'll show you some of the detail around that in a moment, and the other speakers will go into even greater depth about those features of the program. So it's a chemotherapy-based episode of care program. So if you take a look at the payments, the payment will be $160. This is the base payment for care management. Will be $160 per beneficiary per month. Over the 6-month period, you bill these if you're a participating oncologist or oncology group using a G code on a monthly basis, and you'll be paid up to $960 for the 6-month episode of care. The program is intended to cover as broadly as possible the oncology community. So if you're a solo oncologist, or if you're an oncologist in an oncology group, or if you're an oncologist in a multi-specialty group who orders chemotherapy, you can qualify for the program. And the program is also intended, to the extent that it can technically do so, cover those who have converted to provider-based status. So oncologists who are working in a hospital outpatient department circumstance. The technical details of that are still being worked out, since that involves some complicated payer logistics. And you can hear more about that a little bit later as well. So there's this base payment, fixed payment, $160 per member and per month, which the oncologist, the participating oncologist, can get in addition to their Medicare payments. This episode of care under which they can get these payments will begin with the first time that they submit a claim, effectively either for chemotherapy administration or for a covered Part D drug that's part of cancer treatment. The bundle will go for the 6-month period, and even if the patient comes off of chemotherapy, if the chemotherapy regimen ends early, you will continue to be able to bill this G code for the full 6-month period. If the patient requires treatment beyond 6 months, then you can reinitiate an episode of care, another episode of care, and continue to be paid under the program, or start being paid once again under the program for an additional 6-month episode of care. Now that's the easier part, is to get the base payments for care and case management. And we'll talk about operationally that's not so easy to do, and Kavita will get into those issues in a moment. But what's a little bit more difficult is to qualify for the performance-based payments. And the performance-based payments are based, as I indicated, both on quality and on cost reduction. So on the quality side, the program works not dissimilar to the Medicare Shared Savings Program, in the sense that there are a number of quality domains and measures which you are intended to try to meet. And depending on the extent to which you meet those quality targets and measures, you will come up with a score, and that becomes your performance multiplier. So if you are 75% compliance with the quality measures and you end up with a 75% score, that becomes the percentage of cost savings that you can ultimately keep up to a cap. And we'll talk about that in a moment. but this becomes your performance multiplier on the quality side. Then in terms of cost reduction, the cost reductions are measured against a cost benchmark. And the cost benchmark is derived from all of the services which have historically been provided by that provider, or really associated with the particular beneficiaries that are attributed to the provider, to the oncologist, including all their Part A, Part B, and if the beneficiary participates in Part D for covered drug costs, as well as the Part D costs. So that will begin to develop the benchmark. It will be risk adjusted, geographic adjusted. The adjustment factors have not been fully worked out yet. But before you can receive any cost savings, if you're able to reduce costs, the government always has its hands out a little bit here. And so there's a discount rate that gets applied, or in the Medicare shared savings world, they talk about it as a minimum savings rate. Here, the discount or minimum savings rate on the first 2 years of the program is 4%. That is, the government gets the first 4% of savings in relation to the cost benchmark before the participating oncology group begins to receive that cost savings. At the end of the second year of the program, participating oncologists have an option. They can either continue just to get upside risk beyond a single track, or they can go to a dual track with downside risk. If they choose, and again, this is not required, it's elective, if they choose to go to downside risk at the end of year 2, then that minimum savings rate, that discount rate, drops to 2.75% from 4%. In other words, easier to achieve cost savings that will go into the pockets of the oncologists. But with that comes downside financial risk. And so to the extent that that cost savings are not only not achieved, but if you exceed your price target, if you exceed this discounted amount, then those dollars need to be repaid to the program by the participating oncologist or oncology group. You do have the unusual opportunity under this program to shift between risk and non-risk tracks on a semi-annual basis if you choose to do so. But you also cannot participate in the in the shared savings until the government has not only recouped its discount rate, whether it's the 4% or the 2.75%, but the government also has to recoup the fixed $160 per month payments which have been made under the episode of care. So they also need to recoup the $960 for that 6-month episode of care, plus the 4 or 2.75% before the participating oncologists get $1. And if you're not able to, as a participating oncologist, if you cannot demonstrate by the end of performance year 3 that you've actually been able to achieve cost savings, then you can be removed from the program. So you got to try. It's a pretty significant hurdle to get to a 4+% cost savings, and you will need to reduce emergency department use. You will need to be able to avoid avoidable admissions. You will have to use generic drugs instead of branded pharmaceuticals where appropriate in order to try to get to that levels of savings to make it worthwhile. In terms of participant eligibility, Dr. Patel will talk about this in depth. Let me just make maybe one point here, which is the first one, that if you're going to be a participating group and you have oncologists in your group who order chemotherapy, then all practitioners in the group that order chemotherapy must participate in the program. So it's all or none in terms of those who order chemotherapy. In terms of selection, Ron Barkley is going to talk about this in some considerable depth. Let me just make a couple of quick points about this slide. One is that it is projected by CMMI that they would like to include at least 100 practices. They'd like to get 100 participating practices in the program and cover at least 175,000 care episodes in order to have a sufficiently robust cohort to study for purposes of this program over the 5 years of the model. Some of the selection criteria are up here. One of the things I haven't mentioned, which is a key feature of the program, is that this is intended to be a multi-payer program. That is, I think people are generally aware, the Medicare program probably covers about 50% of those patients who have cancer in the United States. The other 50% are covered either by commercial insurance, employer self-funded insurance, or governmental programs like the Medicaid program. And part of this particular OCM model is to encourage those who participate to also bring along or also participate with other payers that are providing similar incentives for quality and cost savings under a similar kind of model. And so there's an application process here, not just for participating providers, but also for participating payers that want to come along and participate in the OCM model. And those providers, those participating oncology groups that participate not only in the Medicare program, but also in the payer programs of these commercial insurers or self-funded plans or Medicaid or state programs that are also participating in OCM will have a leg up in the process. They will be favored in the selection by CMMI to participate in the OCM program. So it's a multi-payer program intended to incentivize the right physician behavior and to impact a broader population of patients with cancer. Now this is a pilot, a test, an experiment. This is a living laboratory, and so there are significant program evaluation elements to the program, and most of them are here on the slide. I mean, the takeaways are if you're going to participate, you're going to need to have the administrative resources and the technological resources to be able to report, to be able to deal with patient surveys and site visits and independent evaluators who are looking at your outcomes and quality and so forth. And there will be a cost that's associated with that. And one of the questions I think that anyone who's pondering participation in the program will really need to think about is whether the costs of participation will be outweighed by the potential benefits, the rewards of the program. Clearly in the program design, CMMI is intending that to be the case, but on a case-by-case individual practice or practitioner basis, you'll need to make that assessment for yourself and make sure that it lines out properly for your practice. And there's also opportunity for learning and sharing best practices through a learning system. This next slide shows you the general application process and timeline. Again, Ron Barkley will talk a little bit more about this. But if you want to participate in the program and you're a payer, your letter of intent is due in about 2 weeks on March 19th. If you're a provider and you want to participate in the program, you need to get a letter of intent in a little over a month, and by April 23rd. And once you apply, you will get back from CMMI electronically a web link and an associated password which will connect you to an online application form. And if you want to proceed with an application, then your applications will be due as indicated here by June 18th. There'll then be a selection process. Decisions out of that selection process will be made in about 6 months, so near the end of 2015. And then the OCM process and program itself begins officially sometime in the spring of 2016, the specific date of which is yet to be determined. So that's the broad parameters and outline of the program. Let me turn you over now to the people who really understand this in the greater technical detail, and let's start with Dr. Patel, who will talk about the program requirements. Dr. Patel?
Great, thank you. Let me just get to the right slide. And I'm going to try to move, this isn't a lot of information, but it's leading to, I think, what everybody wants to get to, which is some of the financial pieces. So I don't want to be sandwiched in between the bulk of information that Michael shared and what Ron's about to share. I'll move through this, but it might be best if anybody has any more questions. There's a great set of frequently asked questions as well as information about the model on the CMMI website. So I'm going to try to summarize kind of what is expected. And I'll just say at the top, kind of on the outset, as Michael alluded to, not only with the multi-payer aspect, but this is a very interesting model from CMMI, one, because it deals with specialists, and a lot of what we've seen so far is comprehensive but really geared towards primary care. But then two, it's asking physicians to really look at total cost of care. So I'm going to reinforce that, and Ron's going to reinforce that in the financial kind of benchmarks. But this is not just the cost related to the care that's under the umbrella of the medical oncologist. It's looking at not only all oncology-related costs, but just as a physician, to put it bluntly, usually people don't have just cancer in isolation. They've also got other diseases and other comorbidities, especially in the Medicare population. So you're also looking and understanding the costs associated with comorbid heart disease, diabetes, et cetera. And I think that is something that most physicians have never really wrapped their minds around, and this is one of the first opportunities from the Innovation Center to think about total cost of care. As you can see on the slide, there are practice requirements that really, I think, constitute the bulk of what we would say is kind of transforming clinical care to the next level, and kind of the three-part or triple aim. And the first, I'll go through these, but just to highlight, the 6 basic ones have to do with patient access, certified electronic medical records, continuous quality improvement in data, as well as patient navigation, a documented care plan that's consistent with the care plan recommendations from the Institute of Medicine, as well as the use of nationally recognized guidelines. So let's move through this so that you can see what the first requirement is, that a practice have 24/7 access to, patients should have 24/7 access to a practitioner who also has real-time access to that patient's medical records. Remote access, meaning telephonic access, is okay. And really the expectation here is for the oncologist to manage care in some way, so that after hours, when the office doors are potentially closed, that a patient feels like they've got an avenue to communicate any of their concerns. This does not say that a patient should not be seen in an emergency room setting or might need to go to a higher level of care, but that the oncologist is really helping through their office and their support staff to really give a 24/7 resource to that patient. The next practice requirement is around electronic medical records. This is actually just consistent with expectations across the country for physicians to be on, not only to be meaningful users of electronic medical records as individual clinicians, but to also use an Office of the National Coordinated Certified Electronic Health Record prior to the start. And by the end of the first performance year, if we use spring of 2016 as the date for the launch, by the end of the first performance year, those practices must attest to be compliant with Stage 1 meaningful use, with the intention of also being compliant with Stage 2 meaningful use by the end of the third performance year. And remember, these performance year dates might shift, so it's basically 3 years after the start of this program. This requirement can be, and throughout you'll see language for a lot of discretion from CMS. This is very consistent with other payer models. So just to step outside of OCM for a second, if any of you have been working with clinically integrated networks who are doing Medicare accountable care organizations or other types of Medicare programs from the Innovation Center or other parts of CMS, you'll note that there's always kind of the jurisdiction and the flexibility for CMS to adjust some of these requirements. So that's also present in some of these practice requirement language. The third is really for around use of data for CQI's continuous quality improvement. I think this is really critical. CMS has made a commitment to provide, at least on a quarterly basis, consistent quality and cost data. So what you'll expect to see is that these practices, and Michael mentioned that anyone from a one-person practice to a large multi-hundred kind of group oncology practice could participate. I think that when you think about these practice requirements, it's difficult to see how a one-person practice could do this in isolation. And for example, having quarterly feedback from CMS and having the ability to also understand and analyze that data itself inside of a practice is a requirement that might require some upfront infrastructure if that's not already part of an oncologist practice. There will also be, CMS will be putting in their own resources to develop a learning network as well as other kind of experts to assist practices in using the data. And if we look at what we've learned from other payer models, we know that that itself is a barrier, how to get these data feeds from CMS into clinicians' hands in a way that they can use the data to change or understand how to change their clinical course. That is a critical piece. And then the piece about quality measures that Michael touched on, he's already talked about how there'll be a multitude of media involved, patient surveys. A good chunk of this is going to be extracted from claims data. And then there's a very interesting aspect to this. Again, this is a reflection, I think, of the Innovation Center listening to input that has come over the last several years about how claims-based data is just not enough. And they've made a pretty giant leap forward to ask for not just claims data for the creation of the numerator on quality measures, but to also use clinical data and clinical data extraction. I think that's going to be something that, as we see CMS and HHS broadly moving towards more value-based payment models, the incorporation of clinical data is going to be important for how those value-based models are constructed. And then I'm not going to go through too much about the details on the different measures, except that there are 32 measures, of which some will be used for payment, meaning the performance-based payment that Michael touched on, and Ron's going to go through some scenarios, and then some for monitoring. We mentioned already that there will be some audits and other ways of making sure, if folks are already thinking about asking the question, how will CMS make sure that care is not kind of stinted, or that patients, that clinicians don't game the system and don't provide enough care. I think you're going to see that there's going to be every intention to not only kind of audit, but to make sure that there is a frequency of assessing whether a practice is not only adhering to measures, but if there's any concerns about beneficiaries in the Medicare program not receiving standard of care, that will be integrated into this ongoing evaluation. There are some criticisms that these are largely process measures. Those of you who are familiar with kind of quality improvement measurement models understand that process measures are a bulk of what we have in the quality field, and however, there are some outcomes measures that are in here. So let's just move to the next requirement around patient navigation. There is some, I put on here the link to the source that's cited from CMMI around some suggested activities that should be included as part of what is considered patient navigation. And this is important to note. CMS does not expect for every practice to hire new patient navigators. Existing staff can be used. Here are this is a sampling of some of the things that navigators would and could do: translation services, community linkages to other services that are beyond kind of what's inside of an oncologist practice's walls. That could include transportation, et cetera. Medical record retrieval, there's an expectation that the practice will help patients have access readily to their entire medical record, as well as potentially coordination of appointments. So again, for the field of oncology, the concept of patient navigation is not new, but it might be something that certain practices, especially smaller practices, would have to think creatively about how to augment their daily clinical workflows to provide some of these services. The next practice requirement is around a documented care plan, and they reference heavily the Institute of Medicine care plan. There's a link there that I would just recommend anybody who's thinking about this and what it might mean for their organization look at. And their highlights from some of the 13 attributes in that care plan include documentation around the diagnosis, treatment goals, as well as expected response to treatment, information on quality of life, as well as the caretakers for a patient, advanced care planning, estimated costs for the patient's care, total and out-of-pocket, survivorship planning, as well as a psychosocial needs assessment. I think these Institute of Medicine attributes are important to remember when people ask that question again of how is CMS going to be making sure that doctors provide not only excellent care but don't stint or under-resource care. this is one of the documents that's going to be heavily relied upon to ensure that at the beginning of any oncology treatment episode that patients have a really robust understanding of what their entire course of treatment would look like. Some places are implementing pieces of this, but it's rare to see a comprehensive assessment to this degree that's being done. So some could argue that that's overly onerous, and many who are in the cancer community would say that this is exactly where they want care to move. The next practice requirement, the final one that I will cover, is incorporation and utilization of clinical guidelines. Generally speaking, the expectation is that you'll either be using NCCN or ASCO guidelines, and those are encouraged. However, if these guidelines are not utilized, as long as the applicant in their process documents why they are not utilizing them, that those are certainly rational causes for exemption. And the reasons for not using NCCN or ASCO guidelines might be some of the following: emergence of new treatment protocols that are not incorporated into the existing NCCN or ASCO guidelines, and then potentially participation in clinical trials. Because there is every intention to include patients who are in clinical trials, there is explicit language that that is absolutely acceptable. So patients in clinical trials would be acceptable in this model. And then I'm going to hand that off now to Ron Barkley, who's going to go over what I know will be a robust set of question-generating conversations around economics and the application process around performance-based payment. Ron?
Thank you, Dr. Patel. I would like to put a little focus on the translation of the OCM requirements to some simulation of the economics, and then some of the details of the expectations of the application and the application process itself. So this grid on this slide, I want to just walk through and pick up where Michael left off on the calculation of the performance-based pay, starting with the Ro1 Benchmark Expenditures. This is a risk-adjusted based on the practice's historic baseline period, which is further going to be tweaked or adjusted for regional variation. So on the slide you're looking at, row 2, it is not the discount percent that is adjusted for regional variation. Move those words up into the first row. There will be a benchmark for each of the cancer types, the major cancer types that will be measured in the program. So it is not clear yet what the baseline period, the look-back period, will be for the determination of the benchmark, the target. The application asks for information look back for 3 years, 2012, 2013, 2014, so perhaps that's an indication that that will be the look back period, but we don't know yet. Might be 2 years, might be 3 years, might be 1 year. So from this benchmark, then a discount percent is reduced either from the benchmark, either 4% for the first 2 years in one-sided risk, or if the participant elects to go to two-sided risk, there's a discount of 2.75%. So that benchmark expenditure minus the discount equals the target price. So it's target price, which is the participant's bogey. You're looking to reduce actual expenditures under this target price. So in the case of one-sided risk, 96% of the benchmark is the target price. From the target price, CMMI will reduce or take out the actual overall expenditures claims for all of the episodes of care during the measure period, and that episode of care basically includes the care management fees already paid. So in a way you can think of the care management fees as an advance on the performance-based pay. So we take actual expenditures off our target and come up with a gain, basically, share the savings. And it's those savings that are now available for the performance-based pay. However, there will be a performance multiplier to adjust for success in meeting quality and performance measures, the 32 quality performance measures that Dr. Patel referred to earlier. It is not yet clear how that will be tabulated, but I guess there will be some assumptions of a percentage success in satisfying the requirements, and that will be a haircut if you don't achieve 100% performance, a haircut on your savings, on your gain. Performance multiplier times the gain equals what the performance-based pay will be, paid semi-annually. Just a second while I can adjust the slides. I'm not getting slide. Okay, there we go. So I wanted to look into what the application of the OCM provisions would be, make some assumptions for basically a start point simulation of what the bottom line could be to a practice who participates in OCM. Some basic assumptions. The number of new patients annually that a busy medical oncologist could expect to see, reduced by the theoretical number of cancer versus heme patients that a community practice may be seeing, which would result in perhaps 180 new cancer patients per year per medical oncologist in a practice. Essentially use a assumption of about 40% of all new cancer patients that would receive chemotherapy. The reference for that is a Milliman client report that was produced in March 2010 that looked at this metric and adjusted for some more current thinking on both the implications of the oral drugs and the amount of drugs that will trigger this episode of care event, and made an assumption of about 40% of Medicare fee-for-service new cancer patients will receive chemo. 50% payer mix. I think that the 50% of Medicare fee-for-service payer mix may be a little high for markets that have significant Medicare Advantage. But for modeling purposes, let's assume the 50% of practice payer mix is Medicare fee-for-service. Next assumption is to target the concept of a 12% overall savings by virtue of putting into place the types of care processes, care management that is envisioned in the program. And that 12% is derived from several sources. The oncology medical home experience, originally documented by the Oncology Patient-Centered Medical Home, Dr. Sprandio's practice, supported by further documented studies of Aetna, Texas Oncology, and by United Healthcare that all seem to support the concept that through rigorous care management, pathways compliance, end-of-life counseling, the type of activities that are envisioned here, that you have an opportunity to reduce overall savings, overall spend by about 12%. The next assumption that went into creating a simulation was to establish what the total medical costs, the claims might be during a 6-month episode of care, our unit of measure. A high, medium, and low numbers used and reference again the Milliman report of 2010 that has established a benchmark discussion point for what the total spend is on a cancer patient receiving chemotherapy. So putting that all together, this is an initial simulation of what the bottom line may look like for a per medical oncologist in a participating in OCM. The first line is a assumption of the total spend at the high level, $110,000 total spend per cancer patient receiving chemo. That is the Milliman number. That is also a number which was a measure of a one-year period of time, keeping in mind that the episode of care that will be measured is 6 months. Let's try a mid-level number, half of that. So $55,000 might represent a mid-range of overall spend that could be incurred by patient receiving chemotherapy. And a low number, plug 25,000, is representative of a certainly a lower spend amount on a particular episode of care. Taking the new patient conversion to chemo assumptions, it may be that 36, maybe as high as 40 Medicare fee-for-service chemo patients would be a number that triggers the episodes of care for performance pay purposes. Next row is the care management fees, 160, 6 months, 36 of them, and an anticipation that the care management fee may generate $35,000 annual per medical oncologist in the model. Next step is to say that the benchmark expenditures, if I take my 36 chemo patients, Medicare fee-for-service chemo patients per year, times the high, medium, and low, there's a simulation of what a total benchmark may look like, expenditures may look like for a medical oncologist, per medical oncologist. Take a discount percent of 4% off of that, and I have a target price at a high mix of patient expenditures of about $3.84 million, half that in the middle, $1.92, and a low that may be as $864,000. So there's a target, a way to come about looking at simulating a target price. Now let's assume that for actual expenditures, the practice is successful at achieving savings similar to what others have experienced previously who have done similar work. So that would result in, as shown here on the slide, an actual expenditures, high, medium, and low. Now if I take my actual expenditures, again assuming that I'm successful at achieving what others have in the way of savings, I end up with a gain, a target price less the actual expenditures, which may look about like $290,000 per medical oncologist for high cost, high expenditure chemo patients, maybe $120,000 range for mid-range expenditures, and as low as maybe $37,000 gain at the low end. Now multiply that. I've made an assumption that the practice has been pretty close to perfect on the quality and performance measures and gets a score of 85% success. Again, that methodology has not been published yet, but I'll take a haircut of 15% or multiply by 85% of what my gain is. And now add that to my care management fees already earned up above. I needed to deduct the care management fees to come up with my actual expenditures, but I actually received them. So now I'll add my performance-based payment line, $246,000 at the high, plus what I received in care management fees to a total that looks like it might be $280,000 down to maybe $130,000, $140,000 at the mid-range and $66,000 at a low range of money in the door for participating. Just for sizing's sake, multiply by 10, a practice size of 10, and it could be at a high end, $2.8 million to the participating practice, to a mid of about $1.4 million, down to $600,000 if all your patients were at a low expenditure range. Since there's probably going to be a mixed bag of patients, look something in the mid, and I'd say that this participation per a 10 oncologist group, 10 oncologist practice might translate to at least $1 million, $1.2 million annual in payments. So that's a simulation based on some pretty broad assumptions, but might hopefully give a bit of a sizing to how this may play out for your practice. Let me switch to the application process. The application itself consists of 4 criteria, 4 buckets. CMMI wants to see your implementation plan. That's a plan for the first 2 years, and an explanation of what you do currently as it relates to the quality measures and the practice requirements, and how you're going to maintain or change those, and a statement convincing them that there's a likelihood that you will achieve savings. So for that criteria in the application, it's worth 40 points. A financial plan, again, as in the implementation plan for the first 2 years, there is also in the financial plan a request for some look-back information on practice revenue by payer mix, by all payers for the last 3 years. Financial plan explaining how you're going to fund the activity is worth 25 points. The third criteria element of the application itself is an explanation of participation with other payers, showing this notion of a multi-payer participation in the program parallel to the OCM activity. There's a request in that criteria to project the number of chemo patients that are expected both for OCM and the other payers. And importantly, CMMI does want to see letters of support from commercial payers that they intend to run parallel and provide a similar type activity as OCM. It was interesting that the participation with other payers criteria is worth 30 points, and the financial plan's only worth 25 points. So it looks like multi-payer expectations is serious. There's one other criteria, the diverse populations, 5 points, demonstrating both patient demographics and medically underserved concerns, as well as plans to treat dual eligible beneficiaries. The approach to the application, I think, pretty straightforward. Those that are anticipating making application really need to conduct their own internal preliminary assessment, both operational. Is there organizational readiness to step into this, as well as the financial feasibility, the simulation on a candidate-by-candidate basis, perhaps similar to what we showed a little earlier here. The letter of intent, and I've labeled it mandatory because without a letter of intent being submitted by April 23rd, you won't be able to submit an application. So that's a hard date. You want to, if you're interested, make sure that a letter of intent goes in. In the application itself, the operational narrative, the implementation plan, and the financial narrative for 2 years will need to be authored, drafted. Submit all of that electronically by June 18th, and I think those that submit can expect that there'll be some type of post-application preparedness activities, since the expectation is that it'll be 6 months, essentially late in 2015, when the awardees or the successful participants are announced. I would anticipate that there will be some dialogue back and forth with CMMI about fine-tuning and establishing the benchmarks. with that, I will turn it back over to Michael Blau.
All right. We've come to that special moment in the program. For those of you who would like to have CLE credit for today's hour-long session, let me give you the secret code. The secret code is D as in dog, 0, not O, 0 as in the number, F is in Frank, S is in Sally. Again, D is in dog, 0, the number, F is in Frank, S is in Sally. That is the code. Take a moment, write it down. If you need to do an affirmation, make sure you put it in your affirmation. Otherwise, type it onto the screen. All right. With that, we have about 9 minutes left for questions and answers. And I see that we have a pretty good queue of questions and answers lined up here. So let's take them in the order in which they were submitted. I'll go back in time here. The first question is, what are PPS-exempt cancer hospitals? So PPS-exempt cancer hospitals are hospitals like Dana-Farber Cancer Institute here, some of the larger NCI, NCCN cancer institutes that are only cancer hospitals. They're not part of a general acute care hospital, not part of a tertiary facility that provides services other than cancer-related services. So they're cancer-only facilities, and they are exempt from the prospective payment system. They're paid effectively still on a reasonable cost basis by the Medicare program. So that's the PPS-exempt hospitals. They cannot, and their providers within that context cannot participate in the OCM program, as I understand it. So that's the first question. Second question, unnecessary hospitalizations is a key cost-saving area for cancer care. How can technology mobile health company partner? How can a technology or mobile health company partner with CMS to be part of the pilot? Kavita, do you have any insight into that?
So I think the partnership for anybody, if any applicant wants to partner with as many necessary entities to accomplish the practice requirements, I think that's the best way to approach a partnership. So if this particular person asking the question has kind of interests around telemedicine or a mobile health company, the best thing would be to understand who in your kind of regional network or social network is actually putting in an application and how your mobile health company could help meet some of those practice requirements. And already we've alluded to some of the possibilities in the literature where we've seen mobile health have a really great role in these comprehensive kind of care coordination programs are around helping to identify patients before they need to go to an emergency room setting or a higher cost setting, and how they can get appropriate care in between some of those kind of high cost settings. So I think the answer is yes, but it has to be, CMMI is not going to manage that. It's going to be through an applicant, i.e. a payer or provider who puts in a letter of intent.
I couldn't agree more. So the next question here is going back to the provider-based discussion we had. Could you elaborate more on hospital-based oncologists? Are they able to participate and be eligible for the same benefits of the program? Let me see what this is. You mentioned technical issues. So I think, Ron, we've been in, and particularly Ron Barkley has been in direct contact with CMMI around this set of issues. So let me turn it over to him to discuss that.
Thank you, Michael. I think that a working assumption is that CMMI does not want to exclude any particular oncology providers based on their arrangements that they may have with a hospital to provide services. So there's an intent, a desire to be all-inclusive. The other working assumption or the target is that CMMI needs to be able to track claims and monitor claims and attribute the Medicare fee-for-service oncology patient undergoing chemotherapy, attribute to a physician's NPI or the practice's TIN number. So it appears as though from a claims tracking perspective, those nuances will be worked out in order to not have an unintended consequence of excluding a particular practice or physician that has an operating arrangement with hospital. So I guess suffice to say that there's a recognition that all should be included, and that the ability to track the claims is going to have to be worked out in order for everybody to be included.
Very good. So, details to be determined. I think the general intent is to try to include as many oncology practices as possible, including provider-based practices, but it is these technical calculation details which still need to be worked out. The next question in the queue is, how do you anticipate the total cost of care if a chemo patient also needs radiation therapy for a brain metastases or the like, that would be included as part of the cost? So I think a partial answer, and Ron, you may, or Kavita, you may have additional response to this. Partial answer is that you're looking at, in building the cost benchmark, you're looking at historic costs, and in a normative population, you would have had some incidences of patients who required both chemotherapy and radiation therapy. So the cost benchmark should reflect that to a certain extent. And if there's also an opportunity, which we didn't talk about, to pool with others, to decide that you're going to pool your data with others to derive a more actuarially sound cost benchmark. And so these kind of circumstances, which may be somewhat rarer or outlier, would be better taken into account in a broader pool. So the answer is, in part, it should be reflected to a certain extent in the cost benchmark, and that does become part of the total cost of care, which is calculated in determining whether or not you met your price target and cost benchmark, as I understand it.
And the only thing, Michael, I'll emphasize is that I think buried in that question is something about intimating, again, what I think is hard for people to comprehend, that all those additional costs, so remember this is looking at, within that 6 months, the total cost of care. So as Michael pointed out, the historical part is correct, and whether it's X years of a look back, as we were assuming kind of 3, but then going forward in the actual kind of performance-based payment calculation, it will include all those additional costs, as well as that example I used with someone who also has coronary artery disease and goes in with a heart attack and has a hospitalization around that, and it has nothing maybe seemingly to do with their cancer, but comes within that time period around total cost calculation.
Yeah, and I think I'd add to that that in the establishing, simulating what you think the economics will be for your organization, essentially establishing what the benchmark might be while Medicare is working on it is a good exercise, and I anticipate that there may be an opportunity to reconcile, or at least know that how the calculation was made that you're presented with, the benchmark calculation was made. And one thing I think is important to watch for, that the ground rules upon which the benchmark was established are the same ground rules that are going to be applied to the actual calculation of expenditures. If cost outliers are included in the benchmark calculation by CMMI, then the same methodologies and outliers should be included in your actual expenditures calculation, and not excluded in the benchmark and then included in your actual. So I think there's an opportunity. There will be an opportunity here to really understand how the benchmark's going to be calculated and applied to you.
So the next question in the queue is, does the practitioner have to be a physician, or are mid-level providers also included? And one of you may have, my recollection is that it would be a practitioner who has prescribing privileges and can order chemotherapy. I don't think that it necessarily has to be a physician, is, I believe, the answer. Is that correct?
Yes, mid-levels are also included.
Right.
Must be included, as if they're ordering in the practice, they must be included in the head count of clinicians who are participating in OCM.
There we go. The next question is, are faculty practice plan departments eligible? I think we've sort of covered the principles for that, but Ron, do you want to review those?
Yeah, I mean, where we think we are with that is, again, a final determination by CMMI as to how they're going to track total expenditures. If the faculty practice plan is providing billing on their own account for their professional services that they may be providing to patients. In other words, they're set up so that they're billing their E&Ms. Then it appears that is a fairly clean construct in which CMMI can work. In other words, E&Ms are billed by the faculty practice plan. The technical component, chemo and otherwise, are provided by the AMC or by the hospital. What is not clear at this point is that if the faculty practice plan, the oncologists, the faculty practice plan are reassigning, and then they are providing their services to the AMC patients, and the claims are being generated by the hospital, by the academic medical center, there may be some complexities in trying to attribute the expenditures to the oncologist who are not generating some trail of invoice or claims. So it's a little bit unclear, but at this point I'm feeling pretty confident that the basic principle of not leaving out a whole lot of oncologists at high visibility medical centers is the intent of OCM here.
All right, so we're at and a little bit past the hour. For those who need to go, that's great. We appreciate your attending today and very much appreciate your participation. We'll take one more question. We have a lot of questions in the queue. If we don't get to your question, we'll try to answer them offline and respond to you. But let me take one last one, and those who have to leave, feel free to do so, and otherwise we're going to wrap up after this one. Will ongoing patient self-reported outcomes data be a data requirement to assess the overall quality ratings of the program? Will ongoing patient self-reported outcomes be a data requirement for the quality ratings in the program? Kavita, can you take that one before you've got to run? I know you've got to run quickly. Or she may have already had to go. All right. So Ron?
The patient survey and patient self-reporting is one of the 32 quality performance measures that will be recorded, so that notion is inherent in the quality measures.
Very good. Well, with that, we thank you all again for your attendance today. Hopefully this has been informative, and we hope to have you attend again a Foley seminar in the future. Thank you to our speakers today for their excellent presentations, and Godspeed to all.